the presenters visible, and following the presentation, we'll be able to send you a link to enable you to share the webinar with any colleagues who might not have been able to join today, so that you can disseminate it across your own systems. If you do have any questions or reflections on the content of the presentations, please could you submit it using the question and answer function, and indicate if you know who you would like to address it to, who you would like to do so. You can submit anonymously if you don't want your name to be included. And you can see on that slide, we've given the box that you need to check to send anything anonymously. We've dedicated 10 minutes at the end to review comments and respond to any questions, so please do give any thoughts. At the end of the session, there's going to be a brief poll for us to collect your feedback on your experience of the webinar. We'd be really grateful if you would contribute to that and support us with developing our expertise in this area. And if you've got any questions or reflections that you would like to share following the webinar, then please feel free to send them to the National iThrive team. The link is there, so ithriveinfo@tavicourt.nhs.uk, and we'll respond to those following the webinar. And you will also, as I mentioned, be sent the slides. So just on to the next slide. Hopefully this is something that's familiar to everybody who's here on the webinar today. This is the Thrive Framework for System Change, and as you'll be aware of, it's a population-based approach to supporting children and young people's mental health and well-being. It's very much about ensuring shared decision-making at all parts of the process, where young people might start to communicate in different ways about their mental health and well-being needs. And it takes that population approach to think about the range of help and support options available. I'm not going to go into detail of the Thrive Framework for System Change today. And if anybody who's on this webinar isn't familiar with it, please do access the iThrive website, where you can get more information. But hopefully through the course of the webinar, you will be able to see the way in which the Thrive Framework aligns with personalisation, and we will use case examples to illustrate the different needs-based grouping offer within the Thrive Framework. So just as a reminder, the 5 needs-based groupings are distinct in terms of the needs or the choices of individuals within those groupings, and we need to be mindful of the different skill mix and resources that are needed to meet the needs of the children or young people within those groupings. So the next slide. Okay, so this is where I now hand over to my colleague, Janet Blair from from NHS and where we'll be thinking about the personalised care and moving on to looking at how it aligns with the Thrive Framework for System Change. So Janet, I'll hand over to you and meet myself now.
Hello, I'm Janet Blair. As Rachel said, I work at NHSE within the personalised care group, and I specifically have a remit for working with sites who want to implement a personalised care offer, personal health budget or integrated personal budget in mental health settings, and that's both children and adults. We've worked very closely with the iThrive team in delivering a children and young people's mental health development programme. It was known as CAMHS development programme, but I'll explain why we've changed that later on. And basically that was focused on working with 13 sites to develop personalised care within their children and young people's mental health services across England. You'll hear from some of the sites a bit later on today, but first I just wanted to try to introduce you to and explain this comprehensive model for personalised care. And I'll also look a little bit at the operating model for personalised care in a minute, because I think it will help to make more sense of the whole model and the different interventions and how those align. So this slide is the comprehensive model for personalised care. It's an all-age, whole population approach to personalised care. And if you look at the bottom where it starts with the whole population, to the left of that, you'll see a column that focuses on the types of interventions that personalised care would introduce staff to. So it talks about shared decision making. You can see already the overlaps with the focus on shared decision making within the I Thrive model. It talks about enabling choice, people having more control over their choices around their care in any setting, and also about social prescribing and link worker roles, accessing people into community-based support that's available for them locally. And again, you'll hear a bit more about that when one of the sites talks about a couple of the sites talk about their offers. If you look to the right of the whole population, you'll see a column that has outcomes. So for people who are accessing universal personalised care, we would expect that to support people to build resilience and enable them to make informed choices when their care changes. If you look at the next group of people, which is people with long-term physical and mental health conditions, roughly 30% of the population, to the left, you'll see that in addition to the universal interventions that would be available to people, we are also offering a targeted intervention, which is around personalised care and support planning. It's the key element of any personal health budget or any offer within the personalised care model for people who have long-term physical and mental health conditions. And we'll focus a little bit on the one-page plan that helps us to develop personalised care and support planning a bit later on. So other interventions that would be offered to people at this point include patient activation, health coaching, peer support, and self-management education. And again, to the right, if you look at the outcomes that we'd be expecting to see there, it's basically supporting people to build the knowledge, skills, and confidence to live with their health condition as best as they are able. Then above that, we reach the kind of pinnacle of the triangle, and this is looking at people with the most complex needs, the people that we are probably most concerned about at any given time. And to the left, you'll see that in addition to universal and targeted interventions, we also provide more specialist interventions, and this is where you would expect to find personal health budgets or integrated personal budgets offered to people. And to the right of the triangle, the outcomes we'd anticipate seeing are empowering people, integrating care, and reducing unplanned service use. Now, alongside the triangle, you'll see that there's arrows, which hopefully indicate that people aren't static, they don't remain where they are, and particularly not within mental health. People exacerbate and decrease in terms of their health and well-being needs, and also obviously throughout people's lifetimes. And so the idea is that these interventions will be offered as appropriate to the person at the point that they require the support or care. If we could just move on, show you in the next slide how this overlaps and aligns with the Thrive framework. So if we start with the whole population at the bottom again, if you look to the left, this would relate to the 80% of the population that Rachel often refers to, who are people who would, children and young people who would be thriving. And what the Thrive model would expect to see is comprehensive prevention and promotion resources in place, shared decision making, social prescribing, link worker roles would all be a part of delivering that kind of comprehensive prevention. And to the right, you can see that the Thrive framework would expect that the population of children who might be thriving at any one time, 80% of that population. If we look at the box that talks about people with long-term physical and mental health conditions and look to the left, this would align with getting help and getting advice and signposting, and would include similar interventions, so health coaching, peer support, self-management education, and also people who need focused goals-based input through evidence-based interventions. And again, if you look to the right, the outcomes are very similar. It's about building knowledge, skills, and confidence so that people can live as best they can with their particular health condition. And then above that, people with complex needs. To the left, the interventions would be getting more help and getting risk support, would be the needs-based groupings. And as it says here, they align very clearly with the more specialist interventions that we might provide through a personal health budget. And to the right, very similarly, It's all about empowering people, integrating care, and reducing the requirement for accessing unplanned service use. So if we could just move on to the next slide. So this goes with the personalised care model. It basically explains how we would expect the interventions to kind of interrelate to each other. And so if you look to the left of this personalised care operating model, interventions, as we said, that would be whole population appropriate, absolutely start with shared decision making, where people are supported to understand the care, treatment and support options that are available to them, their risks, benefits and consequences of the options available to them, and are enabled to make a decision about the preferred course of action as much or as little as they can, but that they are involved, as you know, to the utmost of their ability to be involved in making decisions, and that other people are involved in supporting where people require that. The idea is that if you follow the arrows down, shared decision making would lead people to be making choices about the optimal medical pathway for them. It's not about necessarily choosing something else. It may be that there's a medical pathway that absolutely meets people's needs, and if so, that's the route that we'd anticipate people moving down. Aligned with that, you'll see that social prescribing and community-based support, so the idea is that people access the optimal medical pathway, but also are made aware of what's already available within the community that might be able to help them to meet their health needs. And then alongside social prescribing and community-based support, we have supported self-management. So we'd anticipate that people would be fully aware of and accessing options that help them to self-manage. And I think during COVID, both social prescribing and supported self-management have really come into their own in terms of providing people with the information and support they need to help them to manage themselves during this period. If you look above that, you'll see that we have personalised care and support planning, again aimed at the more or less 30% of the population who are people with long-term physical and mental health conditions. Personalised care and support planning is different to the kind of support planning that we offer at the moment. It's a very proactive, very personalised conversation which focuses on what matters to the person, starts with the person, rather than us starting conversations that are along the lines of, can you tell me what's the matter with you? Can you tell me, what brings you here today? We're not looking at that kind of problem solving. We will as the process continues, but we very much start from a basis of, please tell us about yourself and what matters to you. And a bit later on, we'll introduce you to one of the tools that we use to help professionals to have those kinds of structured, personalised conversations with people. At the point that you have a plan in place, there is nothing stopping you from going back to re-looking at social prescribing and the community-based support that's out there, looking at optimal medical pathways, looking at supported self-management. It's about maximising what's already available to support people to manage their health and well-being as well as they possibly can. The personal health budget or integrated personal budget will be an amount of money that you decide on within your local environment based on the based on the needs of the people that you're working with, that would be available to support that person to optimally manage their health and well-being where there isn't a community resource, or the community resources that are available just aren't suitable for the person. And around the outside of these, the description of how the operating model would work are what we call the enablers. We always talk to sites about when they're setting up a personal health budget offer or offering a personalised care intervention, involving their finance teams and commissioning teams in establishing the offer. It's really important that finance and commissioning understand how the model works, and the key points within the system that sign off is needed, and how their role may change in relation to a personalised care offer. What we've found is often that where people are offering personal health budgets, but when commissioning are involved, it's really helped them to see where there are gaps in service provision and become much more responsive to that. On the left-hand side, we also really emphasise the need for involving your senior leadership and helping them to understand what's different about this model and what the key elements are. Co-production with people who access and use your services. We emphasise that right from the outset, you know, the best plans are always laid with people who are accessing services, because they understand mainly what the problems are that need solutions. And then last but very much not least, there is the workforce enabler. This model will require training. Your workforce will need to understand what's different to what they do now in order to maximise the effectiveness of personalised care. If I can move on to the next slide, please. This is a lovely document, and these come as single diagrams as well. They were developed by people with lived experience of services, and they just explain really the shift in relationship that we anticipate seeing if personalised care is implemented and implemented well. So if we just look at the male figure in blue to the left-hand side, what we anticipate seeing is that the system moves from treating someone as a patient with symptoms or separate conditions that need treating in bits and pieces, to being seen as a whole person with skills, strengths and attributes, as well as some needs to be met. I think everybody listening will be familiar, either for themselves or through delivery of their services, times when absolutely appropriate evidence-based interventions are being delivered to people, but they're being delivered in isolation from what is really important to that person in their life at this moment in time. And we often find that, where that happens, this is where people end up bouncing in and out of services and coming back time and time again. You will have access to these slides obviously at the end, and all of the information on here is on the NHS Future Collaborative. And there's a slide at the end which tells you how to access that. If you could just move the slide on, please. So now we come to specific examples that demonstrate how personalised care and the needs-based groupings align. So I'm going to talk about thriving, and then I'll introduce you to some colleagues who are going to talk about their sites offers and how they fit with the needs-based groupings there. So with this one, as I said before, and as Rachel has said many times to me, we'd expect that 80% of children and young people would be thriving at any one time. And it fits within the personal health budget agenda as part of our universal offer. And it's about enabling a whole population to thrive. And to do this, you need comprehensive prevention and promotion resources in place. And as I said before, the benefit of a budget sometimes is that it identifies what's missing in commissioning terms, and also whether the things that are commissioned or provided locally maybe need to be slightly adjusted in order to meet the needs that people are very clearly describing in their personalised care and support plans. There are two examples here, just very brief examples actually taken from the Looked After Children pilot project. The report for that is on the Collaborative Children and Young People Mental Health page. And as I said, you'll see the link for that at the end of these slides. So the first one related to a young person who's used a very small amount of money to access Keep Fit classes at the gym, which has led to them losing weight, which is something they wanted to do. They felt that it's led to them being promoted at work because, they're generally doing better and feeling better, and greatly reduced their reliance on substances, and has led to them being able to stop all medication for depression and anxiety. Without the access to the gym, without that initial small amount of money to enable them to access the gym and realise the benefits of the gym for them, these outcomes may not have been possible. The next one is a young person who had been assaulted and experienced depression and anxiety as a consequence. They were referred for improving access to psychological therapies input, but during that time, their social worker referred them to have a personalised care and support plan to see if there was anything else that could be provided to support them. And it was agreed that the young person would be supported financially to access some local singing lessons. Through accessing those lessons, the young person decided that at this point they didn't need IAT because the singing was helping them to manage their mental health. Again, for this young person, they've been able to access something that maybe will provide them with support for a lifetime, which they may not have accessed in other circumstances. So if we could move the slides on, we focus on getting advice and signposting and getting help. And my colleague Hannah Jenner from Islington is going to talk to this slide. Hannah, are you?
Yes, I'm here. Hopefully I've popped up and people
Yep, you have.
Excellent. Hello everyone, I'm Hannah Jenner. I'm the Senior Emotional Wellbeing Worker within Islington's Social Emotional Mental Health Pathway. This is a new mental health pathway situated within Children's Services, which includes CAMHS, Commissioned Counselling Service, and added in a new service, us, the Emotional Wellbeing Team. And our team sits quite interestingly across the getting advice and signposting section of the I Thrive model and the getting help section of the model. So young people are referred to our service and it helps provide that targeted support, but we operate on the social prescribing model. So young people referred to us are, we consult with them and support them to identify their own well-being goals. They come to us for low to moderate well-being needs, but they also may be accessing targeted services through counselling or CAMHS. And they plan with us how to work towards those goals using the mostly universally accessible community activities available across the borough of Islington. By situating their recovery in these easily accessible activities and services, and in the things that truly matter to that young person and have a role in their life, we aim for the young person to kind of understand the importance of what we sometimes call everyday well-being for getting well, staying well, and be able to self-manage their well-being by looking to health solutions that work for them. And then if things change for them, making those informed choices about getting more help or looking to community solutions to keep them supported. And I've always liked the phrasing used by Janet and the team that's at the top of the personalised care poster that we've just seen. So rather than focusing on what is the matter with the young person, we do take the approach of asking what matters to them, what do they want to get out of this, and help them build that life full of opportunities to be independent, to be capable and connected, and also to have fun, which sometimes in the serious world of mental and physical health can sometimes feel like it's missing, and we're perfectly placed to open up that door again. We should say the PHB offer has been a great addition to our service to help young people maintain their well-being, and it's opened up more avenues for personalised approaches, especially during the pandemic, where the community services that we would normally link young people into and facilitate introductions to have had to close down. So one young person who came to us just before the lockdown hit, in response to her anxiety around her schoolwork and bullying amongst her peer group, she wanted to try new things and develop an interest just for herself to help her move away from these issues. and she won an online baking competition during lockdown, which was a huge boost to her self-esteem, which opened up the opportunity for using a PHB towards some baking equipment for her and a postal bake club membership at the moment, which has helped her build on her skills. She's feeling really capable about what she can achieve there, and she's got a new peer group online of these keen bakers. I should add that her journey hasn't been straightforward. She wasn't just engaging with us, she was engaging with counselling services after speaking to her mum about some self-harm. And as Rachel pointed out in the introduction, the skills needed to respond to these different levels of need are distinct, but we are working alongside the counsellors with this young person to really benefit her, which is the great part about our integrated setup, which incorporates CAMHS counselling and our social prescribing offer. But her case, I think, does show how people can move across or occupy different sections of the Thrive segments at any time, but still receive that personalised care. And how, going back to the earlier slide, it's still important for people with those specialist or targeted intervention needs to be able to engage with those everyday positive community activities that build that world of well-being for them to get back to. So we've certainly found the Thrive model, and especially when mapped to the personalised care triangle, to be really helpful in thinking about our practice and keeping the focus on the how of what we do, and to help deliver those outcomes for and with young people. And if you've got any questions about our setup and how that works for us, please just ask in the chat box or the Q&A. But that's me.
Thanks, Hannah. I don't know whether you want us to respond to questions as they're coming up or not, but I did notice there's in the chat box a query about the use of language and us using the term social prescribing. What I should point out is that the sites, as they implement this offer, many of them are either part of the VCSE community, as with the Islington Centre that, Islington team that Hannah's just talked about, or working very much in partnership with their local voluntary sector organisations, and the language that's used is kept as simple and straightforward as possible, that's front facing, but obviously for us working behind the scenes, it's the language of the NHSE, and so we're trying to explain to you how the model works. How you utilise it and describe it is the more personalised that you can be about that, the better. I think we would all agree. If we could just move on to the next slide. So now we have Helen Farmer, who's going to talk about the Thurrock offer. Is Helen on the call?
I am, sorry. I was just
right.
myself.
We're going to show the video at some point as well. So
yeah, so I think someone else has to click on that for me at the end. But I'll because the video is quite long. I'll talk very slowly. Would you like me to share the video, Janet, on this presentation, or?
Yes.
Yes. Okay. So I'll speak very quickly. So Thurrock CCG. So I'm Helen Farmer. I'm Assistant Director of Children and Young People's Commissioning for Thurrock CCG, and I suppose one of the things we've developed alongside the wider local transformation plans for children's mental health is our local pathway called Positive Pathways for Children and Young People. This is very much a collaborative approach with our CAMHS services, or our mental health services, with our third sector providers, and with a variety of social and community assets within Thurrock. The most important thing at the beginning of the development was really about collaboration, about getting together around the table and really creatively thinking about how we can support particularly our young people who were preparing to be discharged from our children's mental health services, to really support them on that next positive phase of leaving mental health services, and to ensure we gave them the best possible support when doing that. We soon recognised, as one of the questions raised on the chat line, actually, soon recognised that the skill base to do that really sat within our third sector providers. They have a great knowledge of what's available within the community, and they could signpost really effectively to wider community assets, tailoring that need to what the young people were telling us they wanted support with. That has emerged to a much wider holistic support for a whole family approach. So the youth facilitator who's employed by Mind is fully integrated into our children's mental health team, sits within the mental health MDT meetings, and can support the whole family's needs in terms of signposting and support regarding finance, housing, and the whole range of support assets that are out there, including specialist and targeted services. The benefits have been multiple, some expected and some unexpected. So one of the things it's led to is that it was a real development in workforce. Our first youth facilitator has gone on to be employed by our mental health team, for example. You'll see on the video that the manager of our mental health service describes it as French windows being put into the clinic to open up the avenues and what's possible, and given professionals in our mental health team real confidence when planning discharge with young people. So I think I'm not going to say any more now, because I know that time is short, and I'll let the video and the people and the young people themselves speak to the programme. But again, happy to take any questions afterwards.
Knowing that I was coming to the end of my CAMHS journey, it was quite daunting at first, because I didn't think there'd be any other help there.
Thurrock CAMHS services were experiencing a high demand and long waiting times for their services, and we were keen as commissioners to look at ways to help them face that challenge. One of the things we found was that clinicians felt that they were holding on to young people into the service and not discharging them.
My worry as a clinician was, where are young people going to go? You know, they're working with us, you build a relationship, you build a rapport, you put your heart and soul into the job, to be fair. And knowing, however, that there's more need out there, there's more young people that need our services. So you're kind of balancing all of the time, you know, when do you discharge, when's the right time to discharge?
So we wanted to find a way of really supporting young people as they transition from the service and move out into the community. It was very important that we developed a person-centred approach and wanted to offer personal health budgets as part of that offer. We developed a business case that was presented to the Collaborative Commissioning Forum in Essex, which was supported and implemented last year.
Kieran, hello.
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 Hi. So as Paula told you about me? Yeah. I'm the youth facilitator for Positive Pathways. Nice to meet you.
At Thurrock and Brentwood Mind, we've employed a youth facilitator to work within the CAMHS team locally. And her role is really to meet with young people, their parents, carers and the therapists, and to look at what their interests are and what they hope to achieve. So it's really a social prescribing model.
Hi, my name's Kiran. I'm the youth facilitator for Positive Pathways, and I work for Thurrock Mind to help young people transition back into the community through offering them extra support.
There are 4 stages to the process. The first stage is a CAMHS worker and a Mind Youth facilitator have a pre-discharge meeting with the young person and family.
So why don't you tell me about a few things, some interests that you might have that I could maybe, just to get to know you so I can see where I can help you.
The second stage is a personalised care and support plan session with a mind worker takes place with the young person and family.
When we first met Kieran, it was after one of Lily's counselling sessions. She got introduced to us to help Lily do things like on the other side of counselling, and she's given me lots and lots of information for the help that's also out there for me.
What kind of things have helped you so far then? Because we've done quite a few things together, haven't we?
Like counselling, like just talking to all different people, like just...
The music school as well.
Yeah.
She had a taste.
It's just helped me boost my confidence, like that's the main thing.
Third stage, the Mind You facilitator sees what's available in the community to meet the needs of the care plan and to support the young person.
As part of young people's personalised care plan, I introduced them to other organisations in Thurrock, such as Thurrock Mind, Prince's Trust, Inspire Youth, Open Door, Peer Mentoring, and Temple Springs, the music school. And I walked them down to the organisation to introduce them to the services.
Stage 4 is the personal health budget, where it is used for young person's needs where there isn't an available community service already identified.
And now you've got your own little circle of friends and, like-minded. Joe shared his interest in music and how he wasn't able to access that in college. So I applied for a personal health budget, and so he managed to get 12 paid sessions for one-to-one tutoring for keyboard lessons.
Oh, it's boosted my confidence immensely. I can now actually be confident in going up the stages.
Joe's never, ever picked a career. He didn't know what he wanted to do, but music, I know that he really enjoys and he loves to do it, and hopefully by this he can do that.
Ellie, when I first met with her, she shared about the lack of the social groups that she struggled with. So part of my work was making groups, and it really helped her meet new friends.
She put me places like Temple Springs, where I got offered a job, and it's given me the opportunity to grow more in myself that I wouldn't have had otherwise.
We're really proud of the work that's being carried out here from our CAMHS services and Mind, working in partnership with wider stakeholders across Thurrock. It's been really exciting to see their relationship grow and flourish, with new ideas coming out every time we meet.
The best thing about the whole project is just opening up. It's almost like we've had French windows put into the clinic, and suddenly we can see the outside community and we can see all the resources that are available there.
40 young people have been through the system so far, only 6 of which have actually required a personal health budget to support their personalised plan. This really reflects the amount of resource and opportunities there are out there in the community for young people in Thurrock.
I know now that I'm very confident when I discharge somebody, there's something else out there for them. There's another kind of plan of care.
I really enjoy my work, supporting young people, seeing them flourish. It's almost as if I'm walking alongside them on their journey.
Like she's an angel in disguise for us.
Luckily I had Kieran and the Positive Pathways worker there to give me more guidance and support that I needed.
Thank you. This video is available on the NHS Future Care Collaborative. Like I said, the link's at the bottom, and there are also videos about some of the other young people, shorter videos just focused on the young people and their individual stories. If we go back to the slides.
Kerry, are you okay with the slides? Thanks.
Oh, fabulous. Thank you. These things always take a bit of time, don't they? So we're Yeah, we're on Tower Hamlets. We've got Raquel Williams from Tower Hamlets, who's just going to talk about the offer that they've developed within Tower Hamlets CAMHS. Are you there, Raquel?
Yeah, I'm here.
Okay,
Hello, I'm Raquel. I'm a project manager working across Tower Hamlets CCG and Tower Hamlets CAMHS service in East London. I've been working alongside CAMHS colleagues to develop our personal healthcare budget offer, which includes our Getting More Help group of young people with complex needs. We knew that children and young people in our CAMHS with SEND, special educational needs and disability, our group we've recognised with high needs, who through feedback we've gotten from them have informed us that current support and provision for their health needs are not always available to them in a way that best suits them at the best time for them. There was a real onus on how can we support this group more creatively and flexibly so they can have greater ownership over their care. We did some scoping and engagement work with CAMHS staff initially, along with engagement work with our young people and parents participation groups that we have in Tower Hamlets to specify the criteria further. It was identified that children and young people with ASD and or a learning disability, either diagnosed or with significant traits, was a group that could benefit from a personalised healthcare approach. And more specifically, those who are out of school due to a breakdown in their educational system, to support them around this, because CAMHS staff did feedback that they sometimes struggled with facilitating engagement with these young people. We have allocated small pots of money for each young person in the pilot, currently from our CCG mental health funding source, and we are thinking more long term where this funding can come from, and we're thinking about transformation and mental health fund sources within our CCG. In terms of the process, a pathway was developed to outline the process from CAMHS clinician seeing the young person for a personalised healthcare review, to the young person then being approved for the personal healthcare budget, if it's deemed that a personal health budget best suits meeting their goal, to the brokerage process, and then to reviewing the outcomes of the activity or resource. So essentially, once the young person is identified by the CAMHS clinician as someone in the criteria group who may benefit from a personalised healthcare offer, they are seen for the care planning review in the context of a personalised healthcare approach. And if an activity or a resource is identified by the young person that will be helpful in meeting their goal, and a personal health budget is deemed helpful in facilitating this, then the young person is then linked for further support with a care navigator, which is quite similar to Thurrock's offer. And this care navigator is from a local community sector organisation who has extensive knowledge of community resources in the area, which CAMHS clinicians felt that they weren't best placed and they needed a bit of support with keeping up to date with what's locally available for their young people. So this care navigator will work jointly with the CAMHS clinician, young person and their families to identify where in the community will best meet their goal. And the care navigator can also help support them with accessing this activity or resource, for example, accompanying them to their first session if helpful. We found that training has been a really important part of the process so far. We've had one training session with CAMHS staff around the personalised healthcare approach and having the conversation, and we've worked through them to develop the process to get their input. And we're planning a follow-up session to also involve young people and parents, and that really addresses some of the issues that were highlighted in the first training session. So we've had to, of course, think about the impact of COVID-19 on the offer, and we've had to look at our criteria, and we now realise that the reasons for a young person to be out of school are now much wider and very different, and there's a larger group of young people within our criteria now that are out of school. And we've had to review the impact of remote working for our staff and young people and revise the process so that it can work smoothly for virtual appointments and support. And we're thinking about how a personalised healthcare offer can be used to aid the efforts to address the impact of COVID on our young people. So, thank you.
Lovely.
Thank you.
I'm just going to move us on because I'm just aware that it's 11:51 already. This is an example. This is another video which I'm not going to play because we don't have the time, but it is available on the NHS Future Collaborative about Nikki, who was a young woman who was one of the highest risk young adults worked with by adult mental health services. And was worked with in a really beautifully personalised way by her key worker whilst in hospital and actively suicidal. I won't run through it because I think the story in the video speaks for itself and we don't have a lot of time. During COVID-19, I'd just like to point out that for a lot of the young people who were receiving personal health budgets for activities, the flexibility of the budget has enabled them to actually, revisit and put arrangements in place that still continue to meet their needs during this time. Can we move on to the next slide? Because I'm really keen that you get to see one element of one of the tools that we use within the personalised care group, and this is the one-page profile. Sarah, if you just wanted to say a couple of things about your use of that would be really nice, but if you could just keep it very brief at this point.
Yeah, can you hear me okay, Jana? Yeah, fantastic. So my name's Sarah Bisp. I'm a case manager for the Durham-Darlington Teesside Partnership, where I work with a caseload of highly complex young people whose needs can't be met by the local offer, so they have additional CCG funded care. And as part of that cohort, we're looking at a pilot project for small grants personal health budgets for the Section 117 eligible young people. So if a young person has been detained under Section 3 previously. So for our cohort, the Section 117 eligible, but they may also have a diagnosis of autism spectrum disorder, significant difficulties managing their emotions, and often high risk self-harm. So the cohort sits very firmly in the getting more help and getting risk support group. The way we bring in the personalised care and support planning, it would be at an initial multi-agency meeting, perhaps a discharge plan meeting or a community sort of team around the family type meeting. I'd introduce the idea of the small grants personal health budget model, and then if the family and young person are interested, we'd go on to a smaller meeting, so identify to talk about the one-page profile and teasing out what the idea of the PHB would actually involve and what that would be. So we'd need to think about who should be at the meeting, obviously the young person and family member or carer. And I'd hope to involve the care coordinator and the social worker if possible as well, but trying to be very sensitive to their needs and what would facilitate that communication with them. And then gradually working through those questions on the one-page profile to really it's about having a more natural kind of conversation. It's a conversation that's really built around them, their interests, things that are really important to them, and not based around the kind of conversations they're probably more used to as coming from health professionals that have previously been very much assessment based and needs of organisations and with jargon. This is just a more natural, open conversation. What is it that you need? What matters to you? It's about their goals, it's their life, it's their hopes and their wishes, and the thing that will make a real difference to them.
Can I just ask that, unless there's something really, really key that you want to tell the audience, if we can just leave it at that for now. I think in the second part we will run through the one-page profile, and if people are interested in knowing more about that, our contact details are at the end, and we'd be more than happy to have conversations with individual sites. I'm just very aware that we've got literally 5 minutes. I'm sorry.
Yeah, okay.
Okay, thank you. Sarah's one of our mentors, so I'm happy for people to get in touch and to have more contact with any of the people that have spoken today. These are just some key messages that are coming from the work that we undertook, which is, primarily people should know at the very least where to signpost to within their local communities, that the voice of children, young people and their families is absolutely key and central to any good personalised care and support planning, and that proactive prevention promotion is fundamental in enabling communities to support mental health and well-being. If we could just move on to the next slide. I think that's mainly that, like I said, I've been promising you the contact, so that's my contact. As I said, if you want to speak to any of the people that have spoken this afternoon, I'm happy to do an introduction so that you can do. And this is the future NHS collaboration platform where all the resources are. And I think there's a final slide. Yeah,
that's just the website for those who are not familiar with the iThrive webpage. And also, I know that some people have joined through different routes this webinar. And if you would like to join the National iThrive Community Practice and receive the monthly updates and information about future webinars, then please do email that address. As we mentioned, you'll get the slides, so you'll also receive it via that route. And please feel free to tweet at those two addresses, at iThriveInfo and #iThrivePersonalisedCare. So that does bring us to the end of the presentation. I know there's a few questions within the chat. So perhaps, Janet, I don't know if I think most of them do link with specifically to you.
Okay.
So the first one is from Francesco Palmer.
Mm-hmm.
How is each STP or ICS measured to ensure that personalised care is delivered on their footprint to deliver 2.5 million PHBs to children and adults?
There are MOUs being negotiated as we speak. Obviously, there's been a delay and a pause during COVID period, but I think that work is underway now. So each region, there are regional teams, NHS teams, who will be negotiating with each STP/ICS what they're calling foundation MOU for personalised care. And with that, there is a COVID-19 annex as well. There are requirements around counting for personal health budgets, personalised care and support plans, and the benefits or referrals into social prescribing in primary care. But I can tell people more about that if they're interested.
Yeah, so you could always email Janet direct for further info on that point. Francesco, that's another question about how do patient and public involvement start a conversation for change towards personal health budgets? So obviously some of the sites that have shared their experience in implementing through the development project might be able to share some top tips on this. The concern being raised by Francesco about shared decision making is not so easy to achieve. So any thoughts from our colleagues who've implemented PHBs would be very gratefully received, I think, there.
I answer that one, Janet. Is that?
No, go on.
Yeah, so our local experience was that it very much started off from a commissioning conversation, and as Janet was just saying, most areas now are developing their MOU around personalisation agenda going forwards, and children's mental health is one of the areas of focus. So it might be within your STP area, there probably is a named personalisation agenda lead. So it might be worth finding out the name of that person and then having a conversation with them to see how you can influence and become involved in those conversations. So yeah, I don't know if that's helpful, Janet. I don't know if that's how I would probably approach it now, because the landscape's changing rapidly within CCG. So but there should be a personalisation agenda lead,
absolutely
nominated.
And if you're struggling to find them in your area, again, do email me and I can put you in touch with the relevant regional lead who will know who that person is.
I wonder if that links with Francesco's next question about how they can help hold their STP, soon to be an ICS, accountable to deliver PHBs. I guess that would be a similar response, would it, Janet?
Yeah, well, like I said, there are numbers associated with the, you know, there's a lot of counting going on in terms of the, you know, the requirements. Although that, like I said, it's been paused during COVID, and we're not quite sure when that will restart. But I have to say, I mean, I'm a mental health professional by background, and I started doing this work in the personalised care arena while still being a mental health professional 3 years ago, and it's massively changed. I think there is a much greater understanding of personalised care and the benefits of it and the strengths of it right across the country. So, you know, I'm very happy, Francesca, to have a conversation with you, you know, by email afterwards, if you know, if that would help.
Thank you. There's an anonymous question around data and the Thrive framework in relation to BAME and LGBTQ populations. I think that it's fair to say that different localities have some degrees of data collection. There isn't a standard around that in terms of the Thrive framework, but if you want to follow up with an email to the iThrive team, we can certainly support you in knowing a little bit more about what work is taking place. Certainly it is work going across the country.
If I could say something just very quickly about health inequalities and personalised care, it's really high on the agenda. We started a piece of work last year looking at with the Race Equality Foundation, who've produced a really lovely starter report looking at Section 117 PHBs and the ways in which they can be utilised to meet the needs of Black, Asian and minority ethnic communities. It's a very small piece of work. The report did a really extensive literature review and came up with some, you know, quite clear recommendations that we will be following up over the next year. So there is quite a bit of work happening in the health inequalities arena around personalisation and meeting people's needs more effectively.
Thank you, Janet. Nick Dykes has asked for an explanation about the difference between social prescribing and personal health budgets. Could you do that in a couple of sentences, Janet?
Well, they're two different elements of the model, but they interrelate absolutely. I mean, if you would start off a shared decision-making conversation with people. That's where that would be always the starting point. And at that point, it may be that you become aware of something, an interest that somebody has that's not being met, and so you would access social prescribing, or you might even be the social prescriber, to use the language yourself, however you view yourself. But you may be then starting to look at what's available in the community that might meet the person's needs. The budget, as Helen described, I think, out of 40 young people that they have offered this process to, with personalised care and support planning, and then social prescribing, they've only needed to offer the budget to 6 young people, and that's been used where whatever they have locally either doesn't meet that young person's needs or it just isn't available, and that's when they've used the budget. So I hope that explains it.
Thank you. There's another question from Francesca saying that we already know what PHBs can be used for, uncertain why a pilot was required. Of course, that was the development project over the past year, wasn't it, Janet, that you used to develop the framework? So perhaps you just want to say a little bit about that. It's now come to an end.
We ran the development programme, alongside Rachel Bethan and other colleagues, and on the collaborative are all the resources that were developed as a consequence of that, one of which was the implementation framework, which is literally a sort of a self-assessment tool, entirely voluntary. It's there for sites to look at and just think through what's already in place. We don't want people reinventing the wheel. We want you to build on what the good practice you've already got in place. And it just takes you through the different stages of developing a PHB offer, and thinking about what needs to be in place, where you are now, how you might start. And there's lots of other resources from the sites on there as well.
Okay, and I'm aware we've overrun, but just one last question from Nick. On the one-page profile, I can't see the part that focuses on goals, hopes and ambitions as described when talking about the slide. Is there another part to this profile template?
Yeah, well, the thing is, it's not a one-size-fits-all tool. It's not just about, you know, by rote following the questions. It should enable a conversation that's all about support planning. In the next section for sites that are part of the community of practice, we'll literally run through it and explain in a bit more detail how you would use it. But this is why I'm saying the workforce enabler is really important, because it's a different approach. It requires, you know, different ways of thinking and engaging with people. You know, so it would need some talking through, and I can only say I would recommend that you get in touch to find out more, and maybe, you know, we could run another webinar where we focus in a bit more on some of the ways of, you know, the practice and how you might implement this.
Great, thank you. Yes, and I'm very mindful we've just gone over that. For those who are joining the next workshop, the follow-on, who are members of the community of practice, you've been sent a separate link to join that. So we'll draw this webinar to an end now. Thank you everybody for your participation, your contribution, to all our colleagues from that development group who've shared their experiences in implementing. A huge thank you. And if anybody does have any further questions, please do feel free to email either Janet direct or the iThrive programme team, and we will absolutely respond to you. So thanks again to everybody. Great to get this webinar up and running, and we'd be grateful for your feedback now just before we do end. Thank you. Bethan or Kerry, yeah, great, thank you. Huge thank you to everybody for voting there. That's really helpful to get your feedback. Okay. I should say goodbye. Oh, no, more questions? Yeah, okay. Okay, we shall end the webinar now, but thank you all very much, and goodbye.